Hello everyone. Today we'll be continuing our lectures on hyponatremia series and we'll know a little bit more about high ADH states. From previous lectures, we understood that patients with high ADH have increased urine osmolality. That means your urine diluting capacity is worse. And thus, the maximum amount of water which they can drink to pee out the solute that they have eaten decreases. In a normal person with hyponatremia, the ADH production should be 0. As you remember, the diluting capacity of kidneys depend upon the state of ADH. As your ADH increase, so does the aquaporin channels, and this will result in more free water absorption, and your urine dilution capacity is going to increase. So a normal urine diluting capacity is 50 milliosmoles per liter, and because of the ADH, your urine osmolality is now 600. Higher the ADH response, higher the urine osmolality. So if you're eating a normal diet of 1000 milliosmol a day, you need about 1000 milliosmol divided by urine osmolality of 600, that is 1.6 liters. So if you drink anything more than 1.6, you will become hyponatremic if your urine osmolality is 600. If you remember, a normal person can drink up to 20 liters of water to excrete 1000 milliosmoles before becoming hyponatremic. Let's take an example of ADH secreting lung cancer. As the level of ADH rises, so does the number of aquaporin channels, resulting in more free water absorption, resulting in higher urine concentration and lower sodium. If this patient drinks more water than the solute, the free water is going to get absorbed by this mechanism and it's going to drop the sodium even further. So for example, if you're consuming an 1000 milliosmol diet, you have no ADH, that means your urine osmolality will be 50. So you can drink up to 20 liters before you become hyponatremic. However, as the ADH levels rise, your urine osmolality increases and the amount of water that you can drink before becoming hyponatremic decreases. So if your urine osmolality is around 600, you can only drink up to 1.6 liter of water. If you drink more than this, you are going to become hyponatremic. Whenever you deal with high ADH state, first step is to differentiate appropriate from inappropriate. And if you remember, low ECV is another stimulus for ADH secretion, which is considered appropriate. If your effective circulating volume is normal, you are dealing with condition like SIAD, symptom of inappropriate diuresis. And as you remember, SIADH is a euvolumic state. If your ECV is low, you are possibly either dealing with low plasma volumes, decreased cardiac output, or systemic vasodilation. These are the few conditions that result in these three states, which will reduce your effective circulating volume. If your ECF volume is high, such as seen in heart failure, cirrhosis, and nephrotic syndrome, where you are retaining salt and water, this is called hypervolumic hyponatremia. And if your ECF volume is low, it is called hypovolemic hyponatremia. How do you assess effective circulating volume? This is possibly one of the most difficult questions to answer in clinical medicine. You can certainly do some physical exam. However, the clinical assessment of volume status has a very low sensitivity, about 0.5 to 0.8. I would encourage you to read this meta-analysis in Cochrane database system in 2015. Clinical assessment of volume status have a very low sensitivity and specificity, so their usefulness is limited. You can use things like skin turgor, dry mouth, dry skin, urine volume and color to have some idea about volume status. However, a better way to approach this is how your body considers your effective circulatory volume to be. And if your body is sensing low ECV, it's going to stimulate your renin, angiotensin, and aldosterone system. This will result in formation of sodium channel in DCT and absorption of salt followed by water. So your urine sodium levels will be very low. Your serum sodium will not be affected by aldosterone because water will follow the salt. A urine sodium more than 30 millimoles per liter has a very good sensitivity and moderate specificity in suggesting a normal ECV. Thus, a urine sodium of less than 10 or FeNA less than 1% would suggest a low ECV. However, there are certain exceptions. If your patient has AKI or CKD, or if he is on any diuretic, these labs will be not accurate. You can use Fe urea if you are on diuretics. Hence, for more accurate assessment of ECV, combine historical and clinical exam data along with the lab test such as urine sodium, FeNA, Phe urea, or Phe uric acid. So how do you work up high ADH states? First step is to figure out if it is appropriate or inappropriate, and for this you use urine sodium and you can complement it with your history and exam data. And if your urine sodium is normal or high, you are dealing with SIAD. If your urine sodium is low, you are dealing with a low ECV, and here you have to figure out if the ECF volume is increased or not. Look for the signs of pedal edema and ascites, and if they are present, you are possibly dealing with hypervolemic hyponatremia, and if they are absent, you are possibly dealing with hypovolemic hyponatremia. To summarize, high urine osmolality is suggestive of high ADH state, and we divide it into appropriate and inappropriate, and we do it by checking urine sodium, which differentiates your inappropriate versus appropriate, and then you assess the ECF volume, which will differentiate between hypervolemic and hypovolemic hyponatremia. Thank you.